I am Roy Fleischmann, Clinical Professor of Medicine at the University of Texas Southwestern Medical Center in Dallas, a co-director of the Division of Rheumatology at Presbyterian Medical Center in Dallas, and co-medical director of the Metroplex Clinical Research Center in Dallas. I'm going to speak to you about clinical aspects, outcomes, and measures in rheumatoid arthritis from EULAR 2011. The learning objectives are to understand the rationale, clinical practice, implications of the 2010 ACR EULAR guidelines for the diagnosis of rheumatoid arthritis, to understand the practical considerations of the 2010 proposed ACR EULAR guidelines for remission in RA, and to understand other patient characteristics which could determine which medications could be employed and their effectiveness in patients with rheumatoid arthritis. So let me start with outcome measures and diagnosis of rheumatoid arthritis in 2011. First, let me review the 2010 ACR EULAR RA classification criteria. In order to be diagnosed with rheumatoid arthritis, the patient has to have at least one swollen joint. If they do, it cannot be explained by another rheumatic disease. If they don't, then there's a scoring system which is set up which will hopefully determine whether or not the patient has RA. And what we're looking for here is a score of at least 6. So there are 4 parts of this. One is joint distribution. As you can see, it goes from 1 large joint to greater than 10 small joints with at least 1 small joint, with numbering from 0 to 5. Serology, whether the patient has a rheumatoid factor or anti-CCP, and depending upon the strength, different score. How long the symptoms have been present, and whether or not the acute phase reactants are elevated or not. And a patient could be diagnosed with rheumatoid arthritis if their score is greater than 6, or there's a high probability they have rheumatoid arthritis. With this in mind, there was a study done looking at the 2010 ACR EULAR RA criteria in clinical practice with a prediction of clinical RA in patients with early undifferentiated arthritis, utilizing the criteria from the Norwegian Very Early Arthritis Clinic. These patients had a swollen joint of at least 1 with less than 16 weeks duration of disease, and the age was 18 to 75. Of these patients, slightly less than half had definite rheumatoid arthritis by both versions of the new criteria. Of these, 98.8%, 82 of 83, with greater than 10 joint involvement had RA versus only 3 of 11 who had 2 to 10 joints. And 95% of patients, 57 out of 60, who had an increased anti-CCP and or positive rheumatoid arthritis also were diagnosed as rheumatoid arthritis. 11 out of 13 patients with clinical RA who did not fulfill the classification criteria were seronegative. Interestingly, about 40% of patients classified as RA at presentation did not have clinical RA at 6 months. And of those 49, 46 had 7 points or less. So the criteria of 6 is helpful, but is not fully predictive of whether or not the patient will have rheumatoid arthritis. The sensitivity is about 86%, with specificity of about 80%, with a likelihood ratio positive of over 4 and negative of close to 0. So the conclusions of these authors were the criteria performed well in predicting clinical RA, particularly in seropositive patients, although it's not perfect. A second study was done which compared the 1987 and 2010 classification for criteria for patients with early arthritis. This study looked at approximately 250 patients with at least 1 swollen joint for at least 4 weeks with symptoms less than a year. About a third of the patients were rheumatoid factor or anti-CCP positive, and the gold standard were patients who were diagnosed with rheumatoid arthritis after 2 years of follow-up. and they estimated the sensitivity, specificity, positive and negative predictive value, positive and negative likelihood ratio. And if you look at the table, you can see that the sensitivity, specificity, positive predictive value, negative predictive value, positive likelihood ratio, and negative likelihood ratio were all similar. In these patients, about 43% of patients were diagnosed with RA by the 2010 criteria and 45% by the 1987 criteria. So the conclusion of the authors were that there were no relevant differences in RA diagnosis using either criteria. Well, let's move on to outcomes and measures and treating to target in rheumatoid arthritis in 2011. At the ACR in 2010, the new ACR EULAR RA remission criteria were introduced. They were developed by a committee using data from clinical trials. And the reasoning behind this is that DOS remission, and when I talk about DOS, I'm talking about DOS ESR, not CRP, although it's also true of CRP. But DOS remission may not be remission, as patients may have a number of tender and swollen joints, even though their DOS is less than 2.6. So what they did was they assessed the ability of candidate measures to predict damage, a change in the Van der Heide modified total sharp score of less than 0 or 0, and function, a change in the HAC of less than 0, and a HAC of less than or equal to 0.5, thought to be normal function, over 2 years. And the best results were obtained by using either of two proposed definitions. One was that either the tender joints, swollen joint, CRP, and patient global were all less than 1. Every one of these has to be less than 1. Or the SDI, the Simple Disease Activity Index, has to be less than or equal to 3.3. And this criteria is much more stringent than the DOS criteria. So the catch, which is the Canadian Early Arthritis Cohort, they looked at remission prevalence in early RA, new criteria versus other criteria. They had almost 700 patients, 70% met 1987 criteria, and 90% met 210 criteria. And they looked at the percent of patients in remission at year 1 based on either a DOS 28 or less than 2.6, the usual definition of remission, or even a more stringent DOS of less than 2, the CDI of less than 2.8, which is the definition of CDI remission, the SDI of less than 3.3, the new remission criteria, or the ACR EULAR new remission criteria of less than 4. And what they found was that the ACR EULAR criteria, the CDI less than 2.8, and the SDI of less than 3.3 were all very similar, and many fewer patients were in remission at 12 months compared to a DOS 28 of 2.6. Actually, half the patients were in remission compared to a DOS of 2.6. And even if the DOS was less than 2, that was a third of patients as opposed to 20 to 25% of patients. So there were two conclusions. The ACR EULAR criteria agrees with the SDI and the CDI, but not the DOS. And the very important take-home point here is that all remission is not the same. DOS remission may not be true remission. What about radiologic progression in patients who have achieved the new ACR EULAR remission versus other criteria? So this was 535 patients out of the BRASS registry from Harvard. And they looked at patients at a DOS remission. This is a DOS CRP of less than 2.6, which is not equivalent to DOS 28 ESR. They looked at an SDI of less than 3.3, CDI of less than 2.8, and the new ACR EULAR criteria where everything is less than 1. And they looked at the percent of patients in remission at baseline, and clearly there were many fewer patients who are in remission with a low SDI, CDI, or ACR EULAR criteria versus the DOS CRP. But if you take a look at the mean annual total sharp score change, and the percent of patients with progression And the likelihood of good outcome, and this is very clear on the probability plot, it actually didn't make much of a difference. There was similar progression, except it looks like perhaps slightly more patients in DOS remission versus CDI, SDI, and ACR EULAR remission progressed. Power Doppler ultrasound can be very useful in determining true remission. So this is a study that looked at 109 patients with RA, treated the TNF inhibitor who were in DOS 28 remission for 6 months. Half of these patients had a power Doppler ultrasound which was normal, and half had a positive power Doppler ultrasound showing inflammation. Of the patients who had a signal, therefore indicating inflammation, 30% of these had radiologic progression. Of the patients who had no power Doppler signal, there was no radiologic progression. What they didn't answer is what about patients in SDI remission or meeting the new SDI criteria? Would this hold as well? So the conclusions are the absence of a power Doppler signal guarantees arrest of radiologic progression, whereas patients who do have a signal are at risk for progression, or at least a third of them are, despite treatment with a TNF inhibitor. And the risk increases with higher power Doppler grades. And therefore, the overall conclusion of this study would be that power Doppler ultrasound may well be a useful tool in evaluating patients thought to be in remission. Well, the new buzzword, particularly at EULAR, was treat to target. And can you really do that in clinical practice? Certainly you can do it in study. Can you do it in practice? So this next slide looks at two studies using DOS 28 remission as a target with standard therapy. No preset order of medicine use. And what was found was that approximately a third of patients were able to achieve DOS 28 remission. ACR EULAR remission was much lower. It was less than 10%, which is consistent with what I've shown you previously. And what they also showed was the use of the most recent ESR-CRP up to 3 months prior to the visit did not affect the validity of the DOS 28. That's important for a clinical practitioner who is trying to calculate a DOS and doesn't have an ESR or CRP that day. If you take a look at the table, what you can see is that using standard therapy, that at year 3 versus baseline, there was a significant decrease in the median DOS 28, percent of patients in remission, patients reaching LDA, low disease activity or low disease activity and remission, and a change in the HAC. So the conclusion of these authors were that treating to target is feasible in routine clinical care using currently available therapy, and it does result in high rates, or at least higher rates, of remission and low disease activity. All right, what about patient-reported outcome measures? So these are two studies, one from Japan and one from Finland, which evaluated the use of the RAPID-3, patient-reported outcome, versus the CDI and the DAS-28. They found the correlation between the RAPID-3 and the DAS-28 and the RAPID-3 and the CDI was fairly high, and the remission agreement was fair between the RAPID-3, the CDI, the ACR EULAR, and the DAS-28, with kappas of 0.45 to 0.6. This is fairly obvious in the diagram shown on the right. So their conclusion was that any measure using 3 or 4 of ACR core data set will measure disease activity well. And each of these, the RAPID-3, the DAS, and the CDI do use 3 or 4 of the ACR core set. The RAPID-3 requires minimal input from physicians and can serve as a useful addition to joint exam in practice. In my mind, it does not mean that if you have a RAPID-3 that you don't need to do a joint exam, but it's helpful. So why is all of this important? Well, we think about outcomes, and certainly the worst outcome in rheumatoid arthritis is death, and we know that that is cardiovascular risk. So in this very interesting abstract, cardiovascular risk in RA has been shown to be independent of disease duration, but varied significantly with disease activity. EULAR, the organization itself, identifies RA disease duration of greater than 10 years as a cardiovascular risk factor. However, in this study, 855 patients, over 6,000 patient years, 90 of these patients developed the first cardiac event of an MI, cerebrovascular accident, or congestive heart failure. But what's shown in the slide is that the cardiovascular risk was significantly decreased only in patients with a DAS less than 2.9 over time, maintained over time, versus other groups. And there was no difference in survival distribution between disease duration of less than or greater than 10 years. It's incumbent upon us as rheumatologists to treat rheumatoid arthritis as aggressively as we can, safely, to obtain the best clinical outcome that we can, as this should decrease rheumatoid arthritis associated morbidity and mortality over time. So the conclusion here is that RA duration does not increase cardiovascular risk over time. It's not increased after 10 years disease duration versus the first 10 years, but it is markedly lower in patients who have a persistently low DAS. All right, what about other clinical tidbits from EULAR 2011? So we think about risk factors associated with GI perforation in RA patients. If we were talking 20 years ago, 30 years ago, we'd be talking about NSAIDs. If we're talking about the new biologics, we'd be talking about Actemra, GI perforation, seen slightly more commonly with Actemra than with other biologics. But in this large meta-analysis, what was shown was patients who have diverticulitis, not diverticulosis, but diverticulitis, or corticosteroids, whether combined with other DMARDs, without a DMARD, with methotrexate, with biologics, all increase the risk of GI perforation, as does being older than the age of 65. So we should be concerned about GI perforation, although it's rare, but does increase with age, steroids, and diverticulitis. The NSAIDs themselves imposed a minor risk. This is another interesting abstract from EULAR, and it compares quantiferon versus the tuberculin skin test performance in TNF inhibitor-treated patients. So this is 150 patients with either ankylosing spondylitis or rheumatoid arthritis. They were screened by history, chest x-ray, quantiferon, and TST. It was found that the TST was more frequently positive than quantiferon. There was clinical suspicion of latent TB in 21 patients based on risk factors. 9% of the patients were quantiferon positive versus 45% of the patients who were tuberculin skin test positive. There was a 56% agreement. 17% of these patients had indeterminate quantiferon results, and these were primarily in elderly, DMARD, or patients using prednisone. But the relative risk of being associated with latent tuberculosis is about 4.8, 50% of the patients with quantiferon positivity, and 21%, still a relative risk of 2.5 in patients with tuberculin skin test. So the quantiferon positivity is more strongly associated with LTBI risk factors, but the question I would ask is, shouldn't a patient who's either a positive tuberculin skin test or quantiferon receive treatment for a prophylactic treatment if they are going to be treated with a TNF inhibitor, assuming that they haven't had BCG? This should be of value to some of you. Alcohol intake and inflammatory polyarthritis. It's from the Norfolk Arthritis Registry. An interesting study. And this is 184 incident inflammatory polyarthritis patients among a population of over 25,000, of whom almost 140 fulfilled the 1987 RA criteria. And they found, as has been found in multiple other studies, that smoking increases the risk of rheumatoid arthritis and inflammatory polyarthritis, but alcohol decreased the risk 16% per each unit consumed per day. So if we look at the hazard ratio, there's a risk of, the hazard ratio is 1.7 risk in smokers. There is a decreased risk of RA in smokers who drink alcohol to little extent, but alcohol intake truly decreases the risk. And finally, we've talked about measuring disease activity, trying to diagnose disease. Wouldn't it be nice if we had a blood test that did this? So this is the utility of a biomarker test in RA. It's a multi-biomarker disease activity, sold as vector test for RA in the U.S., and they looked at 126 patients from the BEST study, and they took serum at baseline in 1 year and correlated with a change in the radiologic score, the Sharp score. And what they showed was that patients who had a decrease in their vector, the baseline Sharp score, swollen joint count, CRP, all had less progression than other groups of patients, including patients who had a decrease in the DAS-CRP, the DAS-28, swollen joint count 44, the DAS itself, patient global, tended joint count, ESR, and the RAI. This is a test which is not ready for prime time. It's difficult to decide how to use this test in practice and how it correlates truly with other disease measures at present. But hopefully over time it will become a valuable tool, or something like this will become a valuable tool. Other points of interest. In the BEST study, anti-CCP positive patients were more likely to have radiologic progression than anti-CCP negative patients, although they had an equal chance of achieving DAS remission and achieved similar HAQ scores. And the anti-CCP positive patients were less likely to achieve drug-free remission. And then there was an interesting abstract from Australia, reasons why patients had MDA or HAD, and this is 3,000 patients, 39% had HDA or MDA. 240 of these patients where a barrier to better control was reported. So, MDA is moderate disease activity, and HDA is high arthritis disease activity or high disease activity. And what were the barriers where rheumatologists elected not to adjust therapy? Irreversible joint damage, patient-driven choice, safety-driven, insufficient time in the current regimen, non-inflammatory musculoskeletal pain. And of these patients, 27% were being treated with a biologic DMARD, and almost 80% with methotrexate and 45% with prednisone. So those were the abstracts that I thought were of interest, and I hope that you found them of interest as well. Thank you for listening.